Good afternoon, everyone, and welcome back to the Dean's Leaders and Lagniappe lecture series, where we welcome public health leaders to share their innovations, ideas, and leadership values that got them to where they are today. I'm Thomas LaVeist, Dean of the Celia Weatherhead School of Public Health and Tropical Medicine, and hosting this event. The origins of this lecture series came from a school-wide desire to give our students the tools and experiences needed to become the next wave of innovative public health leaders through those opportunities and to meet and learn from some of the most distinguished leaders in public health. We aim to build a bridge between our future leaders and our current ones. This lecture series also boasts something distinctly New Orleanian, lagniappe. Lagniappe is a concept that you'll find throughout Southern Louisiana, and it's an idea of adding a little something extra or unexpected to an occasion. We have adopted this concept of lagniappe by incorporating the arts into the public health lecture series. We hope after this lecture, you'll take a little time to discover the art exhibit in the DuBois Gallery titled Musings, which emphasizes the important role that self-care and mental health play in a healthy society. This exhibition is part of a series of shows that will be rotating in the gallery throughout 2026. And now let me introduce this month's speakers. Dean Paula Song is Professor of Health Services Management and Policy and Dean of the College of Public Health at The Ohio State University. Yes, you have to say the. You know, as a Michigan alum, it hurts to say that, but okay. The Ohio State University. Dr. Song's research enterprise includes healthcare finance, accountable care organizations, payment reform, community benefit and utilization, and access for vulnerable populations, including the uninsured and children with disabilities. Her current research interests focus on innovative financing and delivery mechanisms to improve the quality of healthcare, improve delivery of healthcare. And I neglected to say that Paula is also a Michigan alum, so she must really have a hard time saying The Ohio State University every day. Also joining us today is Dr. Brad Pollock, a distinguished professor of epidemiology and chair of the Department of Public Health Studies at the University of California, Davis School of Medicine, and chair of the Graduate Group in Public Health Sciences. He's a leading researcher on the epidemiology and control of childhood and adolescent cancers, including environmental and genetic cancer, causes of cancer. So today, they'll be speaking about their leadership stories. Thank you both for being here today, and I'll turn it to Dean Song to lead us off.
Thank you, Dean LaVeist, for inviting me here today. I'm delighted to be here. And the timing couldn't be better, right? So do I just go forward? Okay, timing couldn't be better because of the season. And so I decided to use my 10 or 15 minutes here to go along with the flow of the Mardi Gras theme here. So I was asked to talk a little bit about leadership and sort of my leadership journey and philosophy. So that's what I aim to do here. And I look forward to having a lot of conversation and Q&A afterwards. So I thought I'd do leadership through the lens of Mardi Gras. And so the way I'm going to do this is I'm going to start with M for telling you a little bit about my story. A for about the College of Public Health at The Ohio State University, in case you're not familiar. And then I will talk a little bit about my own research and teaching interests. I had to come up with a D for, when you decide to do something clever, it takes a little bit of stretch here. And then I'll talk about my guiding principles around leadership, and then pivot for a little bit about reflection because I needed an R, and I thought this is a good time to insert some reflection, my approach to leadership, and then some smart advice given to me that are daily words that I try to live by. So let me tell you a little bit about my story. So I had very early influences. This is my first faculty identification card at East Carolina University, which is in Greenville, North Carolina, which is where I was born and raised. My father was a political scientist at East Carolina. My mother is an anesthesiologist. They somehow ended up in Eastern North Carolina as Korean immigrants in the 60s. And so this is how I had my early influences of both healthcare and academia. And you put those things together and you get someone like me. From there, in terms of that leading to a career in academia, I did all of my graduate training at the University of Michigan in the Department of Health Policy and Management in the School of Public Health there. my very first faculty position, and I'll go into a little bit more of my timeline, was at The Ohio State University, leaving Michigan after I finished my PhD. After some time at Ohio State, I was then recruited to UNC Chapel Hill in the Gilling School of Global Public Health, and then at VCU, and now back to return at Ohio State. In terms of my leadership journeys, you know, in this timeline, you sort of see the places that I've been, with the exclusion of my current position here, which is now dean. But I started as a healthcare administrator. So I received my MSHA from University of Michigan, and I actually came here and did my administrative fellowship at Ochsner. And so that was, Ochsner was a much smaller place than this was pre-Katrina world, but I had a year-long residency there and then ended up staying on to work on the clinic side of the health system. That was a great experience for me. So it's even more fun to me to be back here because I feel like, you know, I had that time here and I am familiar with New Orleans and I do love it. But at that time, after I was finishing up that stint, I wasn't quite sure what I really wanted to do. And I ended up reconnecting with faculty at Michigan, went back to pursue my PhD. And as I said, my first position was at Ohio State. This sort of journey and my academic journey was pretty traditional in that I went through sort of the traditional tenure track trajectory more or less on time, right? So even though I've been a lot of places and it looks like I can't keep a job, I actually did meet the expectations at each place, which I like to think made me marketable and attractive for the next place that was interested. But I started out at Ohio State and I was an assistant professor. I did make tenure there. And shortly thereafter, UNC Chapel Hill was really interested in someone with my expertise and research. And that was a place, you know, that I was born and raised in North Carolina. So it made a lot of sense. I thought that I would spend the rest of my career in Chapel Hill. My family had all sort of returned to that Triangle area. It's a lovely place, great institution. I renovated a house from top to bottom thinking I would die there. And then it ended up that VCU had a position as a department chair that I was willing to explore that opportunity and it looked really attractive. But one of the things that you'll notice in sort of this timeline, I know there are a lot of words in here, is that I had opportunities for leadership at various institutions. So when I was an assistant professor, I didn't do much in a formal way. I was very involved with the MHA program. It's, those of you who are involved in it, you know, there's a lot of faculty involvement with the students, lots of events. When I was at UNC, I was asked by my department chair to be the program director of all of our residential master's programs. So that included the MHA, our MSPH, and then our MPH program there. I resisted, said no probably 3 times before I finally said yes, because I was still in this associate professor track and I was a little bit worried about getting, and I had just gotten this big grant, I was a little bit worried about getting off track in that trajectory. But eventually I did. We worked out, you know, sort of a deal. And that really led to my first sort of formal leadership position in academia. After doing that for a few years, this opportunity at VCU to be the chair of the Department of Health Administration came up. And I wasn't really looking to move. I wasn't really interested in a chair position. But I had this opportunity to serve on a national search committee for one of our associations for a CEO role. And being part of that search committee really opened my eyes to see many of my colleagues from institutions across the country applying for this CEO position. That made me really stop to think, I should probably be more open-minded and be willing to learn about other opportunities that are out there. And so I agreed to talk with the search firm that was leading the VCU search committee. That one thing led to another. Next thing you know, I'm starting a job in the middle of COVID and life is really simple. After being at VCU for a few years, my current dean at VCU left to become a university president, and they invited me to serve as the interim dean of the College of Health Professions. That's where the health management department was located. So I was able to serve that role for about 15 months. And I think that really helped set me up for success in my current role as dean at Ohio State. So let me just tell you a little bit about Ohio State, really brief and high level. So we were established as a college in 2007. So we're really a relatively young College of Public Health, but we were the first accredited school of public health in the state of Ohio. One of the things we like to pride ourselves in Ohio, because if you know one thing about the Ohio State is that we are big in every dimension. We have over 60,000 students. We like to do things big. Our college is relatively small, and what we like to pride ourselves in that we make a big university feel small for our students that are in our public health programs. And so we're a close-knit college where there's a lot of focus on connections and mentorships. We're nationally ranked top 20 College of Public Health, and in particular, our MHA program is ranked 5, at least right now. We'll see what happens this year amongst all programs in health administration. We have a lot of terrific research happening in sort of all of the typical areas. Some of the things that we're particularly strong in is around cancer prevention, reproductive sexual health, tobacco control. Those are some of the areas that our college is sort of well known for. But because we are on a campus where we have the 7 health sciences schools, so medicine, dentistry, vet, pharmacy, nursing, I'm missing some, but it gives a lot of opportunity for collaboration, which also leads us to a lot of ways for us to provide educational opportunities across the university. So of course we have our undergraduate, our MPH, our MS, our PhD programs. And then we also have a lot of joint dual degree programs with a number of the colleges at Ohio State and a number of different certificate programs that are emerging. So we have now probably closer to 800 students right now pursuing some kind of degree in public health at Ohio State. Let me pivot and tell you a little bit about my research interests. Remember, we're on the RDI of Marty. So my research interests, I'm really a sort of a health management person, and my focus and training for my dissertation was around the financial management of healthcare organizations. I'm really interested in sort of how money shapes decision-making in all sorts of ways. And in a lot of ways, the funded research that I've done is around payment policy. So we've had a lot of changes in different types of payment policies. And how does that impact both the provider experience and the patient experience, whether that be around the delivery care or access to care or other issues. So the work that I'm most focused on right now is this bottom on the North Carolina Medicaid transformation. This is work that I started when I was on faculty at UNC and have now been able to continue for the last 7 years. North Carolina's program is under a 1115 waiver, and that was primarily around a transition from a fee-for-service system to a Medicaid managed care program, with this idea that there would be value-based payment incentives baked into it, also sort of non-healthcare related pilot programs and substance use disorder. So I'm on the evaluation team that is, it's all 1115 waivers have to have an evaluation component on it. So I'm on the evaluation team that has been sort of tracking the progress of this, what they like to call the Medicaid transformation in North Carolina. And so that program has been going on, I think literally since 2019 is when we started. It got a little delayed because of COVID. And that's been my longstanding program project now, and something that I've been able to do and maintain even as I've moved into some of these administrative and leadership roles. In terms of teaching, my area of teaching focus is around accounting and finance. So I teach in the MHA programs. I've always taught basically the same classes: managerial or financial accounting and corporate finance. I've had the opportunity to be a co-author on this series of textbooks that was really started by Luke Kopensky at University of Florida, as well as Bill Cleverly, who was a finance faculty at Ohio State. And this has just been really a great way for me to keep up my teaching sort of skills and thinking about how we teach students. And so I'm very, honored to be part of this textbook series. And there are, in the Kopensky series, 4 distinct different textbooks because they are used in many MHA programs across the country. And being able to further the work of Luke Kopensky has really been personally satisfying. So those are my RDI, research didactic interests. Thinking about my guiding, I think I missed a word, guiding here was supposed to be for leadership principles for G. What I think about when I'm as a leader, and these are things as you get into some higher level, more formal positions and thinking about really what is your approach and how do you approach leadership. For me, these are some of the main things that I come back to when I think about it. One is compassion. Now more than ever, but particularly over the last 5 or 6 years, there's a huge call and need for compassion amongst us all, and particularly as a leader, right? We're balancing, we want to continue to move a unit organization forward, but do so in a way that we understand that there's a lot going on in people's lives and in the world through, particularly as COVID, brought it into focus for all of us, but really leading with compassion and understanding that your team are individual people and they all have individual issues, and how can we be supportive of those and yet maintain sort of the standards and expectations that we have. Second is around empowerment. I feel very strongly my job is to help people do their job, right? Not do their job for them. And I really want to be able to provide those opportunities to people on my team to be able to carry the ball forward. Third is around inclusivity, and that is around how do we make sure that we have the right people at the table, right? Are we getting the perspectives that we really need, not just the people who think like me, but people who can represent various stakeholder interests to help inform our decision making. And then the fourth is around transparency. This is really important to me. I'm generally an open book, and what becomes challenging is when you become a leader is that you can't be an open book about 100% of the things, but I try to be as transparent as possible around the things that I can share, because I think it really helps the team understand how decisions are being made and what's driving those forces. Stepping back to take a little reflection of like, how did I get here? I've had some of these conversations before. It was never my goal to be a dean of a college of public health. If you had asked me this question 5 years ago, do you think you'd be a dean? I'd say no, right? So how did I get here? When I reflect back and you think about it, one is really being open to opportunities. And this started, when I was a graduate student. I was invited when I was at Michigan to be the student rep on, say, a search committee for a faculty position. When I graduated from Michigan, they invited me to serve as an alum on their alumni advisory board. As a faculty member, assistant professor, associate professor, being on search committees for faculty searches or leading those searches. And then generally just being willing to say yes when it was possible to things that came my way, even if it wasn't squarely something that I felt like I knew how to do or wanted to do. I think the second piece is really to embody a mindset of continuous learning and really have a growth mindset around it, which is kind of easier said than done, at least for me. But part of that is really making sure that, thinking about the mentors that I've had throughout my career and role models and models, leaders that I admire and things I admired about their leadership and things that I didn't admire, right? And taking inventory of those things about how I want to show up when I have the opportunity to be a leader. I've participated in a number of leadership development programs, and I put this in here because sometimes when you're invited to participate in one of these leadership development programs, you may think, I'm not ready yet. I'm not at that stage because I'm not a formal leader. Or two, I don't have time because this is going to take a lot of time out of my regular job to do it. And I would encourage you, when you have the opportunity to participate in some of these things, to do it, because you learn a lot about yourself, but it also really helps to build your own network. And the third piece I'm going to put in there is around coaching, and this is just a plug for coaching. I have used an executive coach in my leadership roles. It provides a really safe way for me to be reflective and sort of bounce ideas off of someone who's neutral. And I myself actually am an executive coach. So I've gone through coach training. And part of the reason I did that is because I wanted that to help inform some of my leadership approach in terms of active listening and reflection and helping people find their own solutions, as opposed to me telling everybody, what to do in the way that I want it. And I'm happy to talk more about coaching to anyone later. And I want to just close by saying I have my approach to leadership. What I think about, one is listening. I think it's really important to be listening and seeking multiple perspectives. Second, building a strong team. A leader is only good as the people that are in the room with them. So this is something that I spend a lot of time thinking about, is building the team, and do I have the right people in the seats, right, with the right seats on the bus type of thing. Third is thinking creatively. particularly when it comes to resources. And when I say resources, I mean both human capital and also dollars. And then 5, which I think is really important, is taking action and executing through and following through on the idea. So too often we have all these great ideas, but we don't set it up to make sure that the project is fully executed. So that is my Mardi Gras, and my S is some smart advice. And I just leave you with this. I have 2 daughters, and this is my youngest. She is 7 years old, and she's sitting in a vat of corn because I guess in Ohio, that's what you have. You have these corn barns. That's what we do. But she wrote me this note earlier this year, and it just stuck with me. And it says, have a great day at work and work hard. And when you're done, have a great dinner. Love, Cora. To Mom. And I think the reason why this stuck with me is that this is kind of how I try to approach every day. Right? You talked a minute ago about balance and well-being and mental health, and all of these things are really important because if you're not taken care of, you can't show up for the people around you. So what I try to do every day is to have that balance. I get up, I go to work, I work hard, and I come home and then I have a great dinner, which for me means spending time with family, doing the things that I enjoy, and not working around the clock, because that is not going to lead to a good version of me tomorrow. So these are just words that I take to heart. I thought it was really cute. She's 7 years old and sitting in a vat of corn, and I leave you with that. Thank you so much for allowing me to spend some time with you. This is my email. Feel free to reach out and connect with me on LinkedIn.
Okay, well, I want to also thank Tom for inviting both of us here, but it's really a pleasure. And I will say that I feel connected to Tulane because my younger son, who's now 33, was an undergraduate here at Tulane, double major in business and political economy. So, and we used to live in San Antonio, and so we would drive here. We were here for all the parents' weekends, and it was kind of fun being a proud Tulane parent. So I'm really happy to be back here. I am at the medical school at UC Davis. We'll talk a little bit about this, but here's just a quick outline. I'm going to talk a little bit about the unique role of academic public health, which is important to point out because the whole world isn't academic, right? I'm going to talk a little bit about our program at UC Davis, a little bit about my path and some leadership opportunities that I was afforded. And we'll end with a little bit of our challenges we've got here and some opportunities. And I have to say, being an old person now, I have the luxury of getting a little bit more chance to work on the things that I think are important rather than just pounding away. So I'm going to talk a little bit at the end about where I think some of public health is going to be headed. So first of all, what do we do in academic public health? We engage in discovery science, and that's what really distinguishes us from perhaps the public health practice world, government agencies. We are the ones contributing to the best practices. We are the ones that provide the evidence, and we're creative in terms of putting that forward. Not exclusively us, there are other people involved, but this is really something that sets us apart from the rest of the public health world. Secondly, we are also working at translating that evidence to practice directly, doing that in an equitable manner to improve the health of our communities, the population we serve. And then last but not on that level here, I just wanted to point out a little special being in a medical school. So we are a large department. I'll show you that in a second here. But some of the special considerations that are important are we do not prepare the next generation of clinicians to treat patients and deliver medical services. 2 years ago, I wrote a fairly big check for our MPH scholarship fund for our program. And I got a really nice thank you note from the development officer for the health sciences saying, thank you so much for contributing to training the next generation of physicians taking care of people and treating them. And I put the letter down, I put the email down for a day or two to cool down. And I decided to use that as a teaching moment, wrote back and said, we don't do this. This is what we do. We don't treat one person at a time. We take care of the whole population. And interestingly enough, I got a very nice response back, and development came to me and said, how can we help you? We're going to help you. And so I've been working for the last year and a half now and at a very high level, which has been great. So, teachable moments, anger, calm down, and then do something that's constructive. Okay. So we also address population health with a big P. You notice I have a little p there? A little p is health plans. It's for a healthcare delivery system taking care of their patients. That's not what we do. We do the big P as in public, right? And where we can, and especially being in a medical school, we do fully leverage having access to our clinical colleagues and using that. And that COVID was a good example where we all had to come together. We weren't thinking about what our original backgrounds were, but how we solve the problem. Okay, lastly, we train the next generation of public health professionals and academics. Very important. That's also unique to our mission. Just a little bit about our program. Our department had its origins back in the early 1980s with a division of occupational and environmental health in the Department of Medicine. Mark Schenker was the person who ran the division and was our founding chair. That morphed through various name changes and organization into its own department. And I got there actually in 2014. We had 3 divisions when I got there, 20 faculty. We had a division of biostatistics, epidemiology, and environmental occupational health. And after getting there, I established a new division of health informatics and a division of health policy and management. And we are about to recruit somebody who's going to start a new division of community health. I'm letting her decide the name of that. It'll be community health, health promotion. But I've got somebody who just came back, had dinner at my house last week for her second trip, and I'm working on that. Okay. We have 5 divisions, as I mentioned, the 2 new ones listed there. And right now we are at 50 faculty. We're still recruiting. As I said, I got there 11 years ago with 20 faculty. I left San Antonio with 20 faculty. So I kind of moved up in the world, or I had to move up. And then we have a whole bunch of volunteer faculty. We call them volunteer clinical faculty, even though most of them are not clinicians. This includes several people and leaders in the California Department of Public Health, as well as our local county health officers for the 2 counties that we're in Davis and also which is in Yolo County, and then the medical centers in Sacramento and Sacramento County. And we have well over 200 research and administrative staff in the department. So we're a pretty big department. These are our educational offerings. The ones that are not in bold are the programs I inherited. And then since I've been there, we started a new PhD in public health sciences about 8 years ago. We started a minor in public health science. We have over 1,100 students. We've graduated 900 students in that minor so far. We will eventually have a major. And then I started a graduate certificate program in public health, mainly to serve some of our government agencies. The California Department of Public Health is located 10 minutes from my office at the medical center. They're the largest state public health department in the country. They have a big professional development group there. I had their director join our advisory committee, and we crafted a certificate program which covers the 4 of the major core classes for the MPH degree, and they can matriculate in with the credit moving forward as well. So that's in its 3rd year of operation now with success. And we have a contract with CDPH to have 30 of their folks every year go through our program. We have many more that have done that. And I just want to point out, we are also very heavily invested in research. That probably distinguishes us. Last year, in the rankings they do for medical schools, we ranked number 4 in the country for public health sciences or preventive medicine. And I was really happy because we have a friendly competition with our friends over at UC San Francisco, UCSF, in their Department of Epi and Biostat. They were bigger. We were on their coattails. We passed them up last year. Yay. And I will say, and I'll just kind of show you, this is kind of our trends in NIH expenditures over time since I got there in 2014. So it's definitely on the right path. And I found out 25 will be higher than this. And in fact, last year it was almost 29 million in NIH expenditures, which is only one metric, but overall our funding includes it's close to $78 million in expenditures. We have a lot of contracts with CDPH, with other state agencies as well, and also DOD and other grant funding, which is not counted in these Blue Ridge rankings that the medical schools tend to use. I'm sorry, just one other thing to say here. If we were a school of public health, we would be ranked, I think, number 12 or 13 in the country. So we're just this little old program in a medical school, but we operate like a school of public health, and hopefully one day we will be a school of public health. This is just showing you the breadth of the research we do. These are areas that we're very strong in: national leaders, top funded folks in the country in Alzheimer's, other dementias, cancer, in neurodevelopmental disorders, basically autism, which we have a huge center for. We have a P30 NIEHS center that really focuses on neurodevelopmental disorders, emerging infectious diseases. We also have we have 2 healthcare economists, and work in areas of value. And because we're in the medical school, we're also very involved in leadership in our CTSA. In fact, one of my faculty is one of the multiple PIs. I've run the Biostat Epi core for many years there. Okay, so my journey. I started out as a kid growing up in the San Fernando Valley of LA in California. I graduated my high school a semester early, and I left the second worst school district in the country, the LA Unified School District back then. Today, the LA Unified School District is the second worst school district in the country still, and got out of there as fast as I could, went across the street to LA Valley College, where I was already a ringer in their marching band, and I was a music major, and I started community college and was there for 2.5 years, taking advantage of the California Master Plan for Higher Education that Pat Brown, Governor Jerry Brown's father, who was the governor when I was a little kid, started to have this float. And it was so easy. Community college, University of California. I had a full ride at UC when I went there. Okay. I worked during my graduate work, which is all at UCLA School of Public Health, now Fielding School of Public Health, did my MPH there in Epi, and then got a job my second year at Cedars-Sinai Medical Center in cardiology, and I worked there throughout my entire graduate years, which were many because I was working almost full time, did my dissertation in cardiology, and was there at Cedars, and then finished. My wife and I were both from LA. We said, we got to get out of here. This is 1988. We weren't going to live here any longer. We decided to look at, I didn't look at any jobs in LA. They wanted to keep me at Cedars. I took my first job at University of Florida because that's what every LA kid wants to do, grow up and move to Gainesville, Florida, right? And I went there because they had an opportunity to work with the pediatric oncology group. That was the stat and data center for that. And I will say that all of the New Orleans institutions that treat childhood cancer and the Children's Hospital were part of the pediatric oncology group. I have many friends here. That was my first opportunity. But leadership came after being on the faculty for about 3 years and working with this national consortium that does clinical trials and other work. I had an opportunity to take over the epidemiology committee, which I did. And then I had about 3 years to get ready for the competitive renewal. That committee in the whole pediatric oncology group for the NCI grant got an outstanding ranking. We moved from very little funding up there. That was my first leadership opportunity. At University of Florida, when I was there, I was in pediatrics. My boss decided to move to another institution and told me that my division of Epi and Biostat and Peds was being disbanded. I better look at another job. And by the way, we want you to come down to Tampa with me. And I got cold feet. The dean called me in and said, gee, Brad, I hear you're thinking about leaving. I said, yeah, because I was told by my boss that I won't have a job. He says, the dean of the medical school said, well, that's not exactly true. And he gave me an opportunity to help form a new department of what was going to be called health policy. But because I was going to stay there, they agreed to change it to health policy and epidemiology. So that's my leadership. I came in as the vice chair of the department, division chief. And then my department chair a few years later got sick and really had major medical problems at a young age. And so I took over as the acting chair and then interim chair for about 2.5 years. So that was another pivot point. And I just remember one thing. I was at a fundraiser for our NPR station there, sat next to the former chair of the Department of History at University of Florida, which was a massive department. He asked me what I did. I said, oh, I'm a cancer epidemiologist. I do childhood cancer, this sort of thing. I said, oh, and I just took over as chair of my department. He says, let me give you some advice. He said, the advice is, you're used to measuring your performance in metrics that you've established that work for you. Throw them out the window. Your job now is to make everybody else shine. And, I was still young and cocky. I had to kind of process that for a day or two, but I did. I took it to heart. And I realized that was really a pivot point for me. And let me just fast forward quickly. I got recruited to go to San Antonio because of the tobacco settlement and dollars that they got, the second in the country to get that. They were starting a childhood cancer research institute. They wanted me to come as deputy director and start a population health sciences program in childhood cancer. I was running the national program anyway, went to San Antonio, built this cancer center with a $200 million endowment. And then there was no academic home for people like me, an epidemiologist or biostatisticians. So I started a Center for Epi and Biostat, and in 3 years, I was able to convince the administration and the Higher Board of Education in Texas to create a new department of Epi and Biostat, which then morphed into really public health sciences. So I was there at Florida originally for 13 years, 13 years at San Antonio, got a call to go out to San Antonio, to Davis. They asked me if I wanted to look at this job. The headhunters, I said, no, I love being in San Antonio. And a week later, I was running the Biostat epi meeting for the CTSA folks. And my friend from Davis was there and came up to me during the break and said, "Hey, you want to have dinner together?" I forgot that he was from Davis. It was a week after the headhunters called. I said, "Sure." And then as soon as I started introducing the next speaker, light bulb went off and said, "Oh my God, he's from Davis. He's going to goad me into trying to come out there." So he did. I had dinner. He said, "You got to come out for a visit." The rest is history. I've been there for 11 years. I only have 2 more years to go. Then I got to move someplace else. So anyway, that's kind of some of the leadership. And I built the department. I didn't build a new department at Davis. That was my opportunity to take a functional department that had been around for a long time and move it to the next level. Okay. Anyway, a couple things about my journey. I'm also a researcher. And I had a couple of very important things I worked on, again, as you might imagine, cancer related. Published this paper in 2000, looking at one of the first papers looking at childhood cancer race ethnicity disparities. I also ran the national study for HIV risk factors for cancer in children. This was a big deal. If you remember, one of the sentinel indications was Kaposi sarcoma for adult cancer. We were seeing more kids getting infected in the 80s, worried about this pandemic we were going to have, or epidemic of cancers related to HIV in children because of vertical transmission. So I started a national study, and this is just one of, we had 7 or 8 papers that came out of this, but this was our JAMA paper. And another thing that I did for fun that was work with a big donor to create a video game for children or adolescents and young adults undergoing cancer therapy to improve adherence. And this was funded by Pam Omidyar, whose husband was Pierre Omidyar, the founder of eBay. And we actually this project was a 5-year project to do a serious video game. And I'll just share with you that of all my papers I published, this has been cited 1,162 times as of last week. Okay, I mean, like nothing compared to my more serious work. But this is the first demonstration of using serious gaming to impact health behavior. So I was very proud of this work. Now I want to pivot to real leadership, and I know we're kind of running out of time, but COVID was the thing that tested a lot of us. And I was asked to put together a couple things. One is my vice chancellor for health asked me to start putting together a model to estimate the number of patients walking in the door in February of 2020. In March, they appointed me to be the chair of the UC Office of the President's Committee, Public Health Committee for COVID. And I ran that with Bernadette, who was just here a couple months ago as one of your guests. I had people from all 10 campuses on that committee. Our first order was to get students out of the classroom and move to Zoom for the whole system. And I did that. And then in April, we put together our Campus Ready plan, which was something I had a lot to do with. And then finally, I got some funding to do a project to launch this Healthy Davis Together project, which I'll just spend a minute talking about. This was a demonstration project funded from private philanthropy to see whether universities and college towns could actually benefit from the universities doing something with their communities, and right at the start of COVID. And so I got funded to get a pilot going, and then moved into more grant funding for more funding from a philanthropic donor. And we started this project, which turned out to be a very big one. I will also point out that Bernadette was on my external advisor committee, as was Amy Fairchild, who was Dr. Song's predecessor at Ohio State, and Rob Califf, who was the former FDA commissioner. Rob had been working for Verily Life Sciences. So we had quite an august group of people that were working on this with me. But we ended up doing this project, and I'll just say, this is kind of the bottom line here. We probably averted, 275 COVID-related hospitalizations, which we modeled based on the population structure, probably about 35 deaths in the small city of Davis. But we learned a lot from doing this. We had many papers published. This was our summary paper that was published in AJPH. And this was an incredibly interesting, ambitious project that ended up costing $50 million. The private donor who remained anonymous during the first part of this was Sergey Brin, who is the co-founder of Google, through his philanthropic organization. And I was briefing him every quarter on the progress of the project. I was told, we know that you're building the plane while you're flying it, so just ask us for what you want. They said, don't think like an NIH-funded investigator. ask for it. And so the project, because the scope kept increasing in size, it went to the whole county, really. It was 50 million when we were all dead, said and done with that thing. So that was what I wanted to talk about in terms of some of my leadership things there. Got a lot of press for this too. It was really nice, national attention for this project. And I was involved in a lot of other things going on around the country with MIDAS, a modeling consortium in California. I led a lot of the efforts with my colleagues. So this was a lot of fun. But anyway, moving on to some lessons learned from COVID here. I think all of us in public health know that we saw the effects of a steady decline in public health infrastructure investment. We were in bad shape. It was bad when I started graduate school in 78. It got worse. Public health orders weren't entirely evidence-based. We know that. A lot of people don't like us public health folks because they were told what to do. I think that a lot of us, and not just us, medical professionals, the vaccine manufacturers, were less than forthright. We knew all along that the vaccines that were being worked on may not confer sterilizing immunity. We didn't tell people that. When they found out that people got infected after being vaccinated, they said, you failed. We could have articulated the message much better. I think we underappreciated the rapid spread of information with social media especially, and the fact that politics got in the way. There were some good things that came out of it. I think there's some technology. These are some examples here. One is forced health exchanges. Sacramento did not have a hospital exchange. We didn't know if somebody was being admitted for COVID in this hospital or UC Davis, and there were two neighbors in an apartment building that went to two hospitals on the same day. There was no way of figuring that out in San Antonio. I mean, that's in Sacramento. San Antonio, where I was before, had a hospital exchange. The CDC, CMS decided no more of this. If you want to be funded for Medicare, Medicaid, you needed to have this. So this became a reporting requirement. We did PCR testing in the community, rapid, high throughput, fast. We did wastewater epidemiology, which existed before, but I think this for disease surveillance really caught on. The vaccine development was nothing less than miraculous, but mRNA vaccines had been used for cancer, melanoma vaccines that go back 10 years, well before the COVID vaccines were available. And then, of course, we learned a little bit more about our modeling, forecasting, which wasn't very good, still isn't great, but we got better at that. And of course, learning how to leverage communications. So some challenges we got here. We're dealing with political polarization, distrust of science, distrust of public health. This is something we talk a lot about at ASPPH and leadership there. Underfunding of our health research, gaps between evidence that we know, evidence-based knowledge, not being put into practice, not being implemented, not being sustained. And also, and I think this is very important, and this is what I'm working on now, the opportunity to better leverage technology to improve population health. I gave a talk about a year ago in Guangzhou, China. It's a conference that Berkeley, Davis, and Sun Yat-sen University put on every couple of years. And I talked specifically about data-driven technologies in public health. These are the three pillars. I'll make the slides available, so I won't read this to you right now. But I think this was really important. And really, if you look at what comes out of this and where technology can actually have application, I think will be very important and needs to be part of our curricula. Absolutely. And we're talking about doing this now with the competencies, getting a lot of pushback from CEF about changing the competencies for this. But precision public health, characterizing the exposome, technologies that help people improve how they live their lives. Obviously, harvesting social media for good, which we do. I have one of my colleagues in communications does a lot of work looking at surveillance as well as developing chatbots with generative AI for health behavior change, geospatial technologies, learning health systems, including public health learning systems, and so on. So these are things I think are really important. This will catch on. This will be important. And the training we're doing for our public health trainees needs to include facility with this. And I will just share with you that Davis, UC Davis in our MPH program had a required health informatics core that we required more than 15 years ago. Okay. So we have a master's of health informatics as well. We have students that will do both master's degrees. We need to get on the bandwagon here, and it's more than just informatics as well. So that's what I wanted to say. And I guess we're going to move to the next thing. There's my email. I'll make the slides available.
We are in a unique era in public health. Typically, government has been a partner to us, but in many ways now government has not been a partner to us. It's causing some of the problems that we're having. Talk to us a bit about the way that you've addressed the context that we're operating in within your school.
Yeah, it's tough times, and the opportunity before us is to really be thinking about how we diversify our portfolio. So I think particularly in academia, we've sort of really focused on federal funding, NIH funding, for our faculty. But there are a whole host of other sources of funding and organizations and individuals who are willing to support research. So coming from a Department of Health Management and Policy, where we've always gone after various sources of funding, that's something that I think more broadly the faculty in our college are trying to get behind. I do think one of the highlights that have come out is that a lot of people have stepped forward on the philanthropy side, and we've had a number of donors who really want to support research, particularly in the areas that are not being funded anymore. So there's not as much money, and there's clearly not money for certain areas of research. And so we've definitely had donors who have come forward to help support continuing that work, which is no longer viewed as favorably by the federal government.
So pivoting, basically.
Yeah.
And so, right, did you
And diversifying.
Did you do any leadership training programs? No, that Paula talked
You and
about.
I did.
Well, I mean, before you became.
Yeah, I did. So I just want to point out, we were actually in the first ASPPH Leadership Institute together. Was that 6 years ago? Something like that, right? 7 years ago? It was before COVID, but then we got delayed because of COVID at the end. Before that, I had done some leadership training. University, UT Health Science Center San Antonio, we started our own, which became a model that the UT system picked up. I've been in UT and UC now. So I did some of that leadership training there. It was about a year-long program. That was very helpful. We got some coaching also, and I value that a lot. I think that I have to say, though, I did it the hard way. I've been around a long time and worked at these places a long time. I made a lot of mistakes. And so before I got my leadership training, I learned a lot about leadership the hard way, not the most efficient way, not a way I would recommend anybody do.
What can you impart to our students? What have you learned that would be a benefit that they could benefit from?
Well, I think a couple things. One is, and I think Dean Song articulated very nicely in terms of the leadership, being transparent where you can be, being inclusive, trying to see the best in the people that we work with day to day, not being hierarchical. That took some doing in my department. There was a very big split between our staff and our faculty, and I'm a non-hierarchical person, and I don't like to be called Dr. Pollock. I'm on a first name basis in my department, and I don't tolerate, I say this is maybe not a nice way to say this, I don't tolerate people pulling rank. And so I have learned that a long time ago by quashing that sort of thing. We all work together. We all have different jobs to do. But the other thing I will say is, in terms of being a servant leader too, getting out of my own way. I have strong opinions about things. And I think the hardest thing for me over the last 2 decades is step back here and let everybody else, play a role here. And I think one of the best example I can have in the last 5 years is faculty expectations guidance document that we put together for our faculty. I mean, what are they supposed to be doing? How much research, how much teaching, what that balance should be? How do we figure this out? And as the chair, I could have said, well, here's what we're going to do, or here's my plan. I was just one of the faculty on that, and I kept very quiet. And we just updated that about 4 months ago. And so I think there's an example of a product that came out by letting everybody work together and having that sort of sense of shared governance there. So I think those are some of the things I learned from all of that. I think the things that we learned in some of the leadership stuff, if you remember, was dealing with difficult faculty or staff and having these simulations of.
Well, I don't have any difficult faculty.
Yeah, I know you don't. Yeah, you and I don't either. Yes, it's all hypothetical. But anyway.
And what about the Ohio State University?
I have no difficult faculty or staff or students, so it's all good.
So I'm really conscious of time. I know students have classes. So if there are any, I'm going to open it up for the audience to ask questions, because I don't want to miss an opportunity. So.
Thank you. Thank you for your very excellent remarks. I'm a research scientist here in the School of Medicine. I really loved your talks, but I'm looking something that you haven't covered yet about your vision for the future. So personally, working in School of Medicine, I have been hearing all the news talking about how big pharmaceutical companies or technology companies that are launching sort of AI health. Even Intel, there's a pure chip factory, have their health department right now. Mm-hmm. So my vision for the future unclear, uncertainty, and I don't know whether it's faster for them to perpetuate in health, or it's faster for public health and school medicine integrating, adapting technology. And as this kind of turmoil time, what's your vision and how public health can stand where we are, not to be pushed by big technology companies like Google, OpenAI,
Yeah.
using their home base or whatever the appliance, and where are our role in 10 years? Thank you.
I just if that's a hard question to answer, quickly, but just to say, I don't think that all of the stuff is coming from industry and pressuring us. I think we are pressuring ourselves. We're trying to catch up. We're trying to figure out what to do. We're seeing an explosion. I use the words data-driven technologies. That includes AI, of course, but and AI. What is AI? Machine learning? Are we talking about generative AI? There's a lot of ways of defining this. I think that we are all learning. We need to be very open-minded. And I will say that we need to think about the role that industry has, not dominating it, but actually as partners. When I was in China, I was just it's the first time I'd been to mainland China, I was just blown away by how they're working over there. Really wonderful colleagues at First Affiliated Hospital there. And they're working with industry also. And, what does it mean? The Chinese government's backing a lot of that. That's fine. Actually, I was really impressed with the fact that we're all trying to work to solve human health-related problems. This was nothing to do with any other nefarious uses of technology there. But I think that what the pitch I was trying to make here is with regard to our academic programs, we can't stick our head in the sand. We need to be training that workforce. I work in a medical school. We're moving that forward as well. Lots of controversy now about whether AI is going to take away their jobs as clinicians. And we don't want to push that. We are talking about it's an adjunctive technology and trying to get the best out of all contributors, so to speak. But it's a scary world, what's going to happen in the future. But I think we have to not look at us versus them any longer. We need to be thinking about what are the problems to solve, how best to do that, without pure evil intent in doing that.
I think there was another question.
Yeah, y'all mentioned bridging the gap between research and implementation. So how do you do that?
That's a great question. I mean, there is a whole field called implementation science, which studies just that. Like, how do we get the discoveries and things that we know to be true, based on evidence into practice? It takes something extraordinarily long, like 7 to 10 years for something to actually translate into practice. So there's a tremendous opportunity there to learn more about how do organizations, health systems adopt, implement sort of the newest sort of standard in practice. That's all along saying I don't have the specific answer, but that is a field, and that is a very important field, and there is considerable amount of funding and support for that kind of work, because we can learn and have evidence for a whole bunch of things, but if we can't figure out how to put it in practice, then it just sits on the shelf.
Yeah, we started our PhD in public health sciences, in addition to EPI and biostat. We have an implementation science track. We have a curriculum now we've established. We actually recruited one of the folks from UC San Francisco who came over, who was part of Margaret Hanley's group there. This is a very important area it's not new. I mean, Ross and other folks were talking about this, 15 years ago. But that is really the science of how you take evidence-based discoveries, put them into practice, not just putting them into practice, implementing them, but it's also sustaining them and doing virtuous, continuous review and evaluation and improvement over time. So there's a lot there, and it's a continuum. And I think everybody who's involved in any discovery science, including even at the basic science level, needs to know how does that fit into the context of where we're going to improve the health of the population. So it's actually, we're doing training through the Clinical Translational Science Award from the NIH, the CTSA institutions. We actually wrote a white paper about 7 years ago about how implementation science needs to be part of the core of all researchers, even the ones doing basic science research.
Okay, I'm going to try to squeeze one more student. Any other students have questions? Would they all leave? Yeah, they're all gone. Okay, anyone else in the audience?
I just want to add to, although there is a science and a field around implementation science, I think we each as individuals and collectively have an opportunity to contribute to that, because part of it is how do we communicate public health? And I don't think we as a field have done a good job about speaking plain language about what public health means and how it impacts everyday life. We can have a tendency to get too focused on maybe the science and the details of it, as opposed to really thinking about how do we simplify our message. And so I think communication in terms of public health and healthcare is really the opportunity for the field to help make public health much more visible and help the public better understand what we do, right?
I couldn't agree more. You know,
And-
my battle with SEEF was about that issue.
Yeah,
When
yeah.
my testimony to them is that we need to require communication.
Exactly, yeah.
We
And-
were
and-
horrible.
And we're underwater right
Yeah,
now.
we're
I mean,
bad.
COVID put us in public health underwater.
Yeah.
We have catch up to do. We were better off before COVID in terms of being a voice. We now have to deal with distrust, and we made mistakes. We have to also fess up to our own mistakes
Right.
and things that we could have done better in retrospect. So it's important.
Well, I think we need to start talking about what those things were so that we can start,
Yeah.
bring them into the classroom. Anyone else?
Yeah. Thank you both for your talk. As public health leaders, do you think we are doing enough for mental health in our public health curriculum as well as in our public health research? Or is mental health primarily the domain of those in medical school? So I'm wondering, I mean, you talk about technology, how we can leverage technology. And I'm beginning to hear now about AI-induced psychosis.
Yeah.
And as a matter of fact, there are some lawsuits now going on relating to AI causing mental health problems.
Well, not to mention the court case in California with the suicide, the
Right.
kid who committed suicide. Yeah.
Exactly. So is there a public health leader, do you think there is room to pivot public health research curriculum to help mitigate some of these mental health fallout? Thank you.
Well, I would say yes. I have to say that our chair of psychiatry, Helen Kales, came from Michigan, where she got her MPH. As a clinician, she's the chair of our Department of Psychiatry here. I don't look at it as public health versus medicine. Again, we're in a medical school, and we work in partnership. We're grant funded together, and so on. So I think that's not the issue. But I think there is certainly under appreciation and certainly not the same proportionate representation of mental health related health issues in public health. I mean, cancer, yeah, we all like to do cancer prevention, and you can go down the list. So there's no question. And of course, as a citizen with family members that need behavioral health therapy, this sort of thing, the health services part of this is ridiculous, where we can't access psychiatry. You know, there's so many issues related to mental health not being paid the appropriate attention to. And I think there is room for public health leaders who have a focus on mental health domain related issues to step up. I mean, no question about that. We have somebody in my department that recruited who's a healthcare economist who got her primary appointment in psychiatry and does work in that union between health services, health economics, and psychiatry, but few and far between.
So we are completely out of time,
Yeah.
and I've stolen a few extra minutes, but I do want to squeeze one more question in for each of you.
Sure.
As you reflect on your leadership journey, is there something you could impart to, I'll speak for our audience now, that maybe you've learned over the years, something you would have, if you wish you would have known early on when you were just beginning your journey as a leader?
I think what I would say, and I talk with a number of students and others around this, is that you'll never feel ready, right? So don't wait. And I say this particularly to women, because women have this tendency to be overqualified before they apply for a job, whereas men just don't. And so you're never gonna, it's true. And so you're never gonna feel ready, but you'll be able to do it, you know? A lot of it, I don't want to say it's just learning on the job, but every issue we deal with is sort of new, right? So really it's about how you think and how you approach problems, not that you've handled a problem like this in the past so much. So I would say if leadership is within all of us, both informal roles and formal roles, you have an opportunity to practice leadership in your everyday life, in your schoolwork, in your teamwork, whatever role that you have, and you got to flex a muscle in order to build it.
I like that answer. And also, you don't have to know all the answers either.
You definitely do not know the
gotta help,
answers.
right?
Yeah.
So I would say relax. If I knew then what I know now, relax a little bit more. Don't be quite as calculating. Things come and go, and the path we were talking about this a little bit earlier with a couple of your students. The paths that we end up in, you could never have predicted that. So don't worry about it. Try to do the best job you can at the time that you're doing it. And so I think from my own sense, I never would have guessed I would have ended up doing what I'm doing in a million years. And that's okay. And I didn't have to worry about that as much as I probably did when I was a lot younger. So that's one thing I'll say. The second thing I'll say with COVID, it was interesting. I became an expert on COVID. Like I did infectious disease epidemiology. I did a 3-quarter class at UCLA because I was interested in chronic diseases. And I thought, well, if I'm going to get my PhD, I should know something about it. And I thought I'd never use it. Well, the first grant I got out of the door was the HIV-related malignancy. So that was helpful. But then with COVID especially, oh my gosh, all that stuff kicked back in. So appreciate what you're learning when you're learning it, because you never know when you're going to use it. And I tell our students at graduation, all that stuff you learn in public health across the different disciplines, you might figure, why am I taking a health policy class when I want to be a biostatistician? I said, but you will end up using everything. And we had a social last week for our graduate program. 2 of our students that graduated 9 years ago came to the social, and they came up to me and said, oh, Dr. Pollock, it's great to see you and everything else. We learned so much. And I said, so are you using everything you use? She says, oh, absolutely. I said, because I've been telling the students that. So I would also just say that appreciate other disciplines, get outside your comfort zone. And the leadership part here, that will come naturally. I think that's the way I kind of look at it. There's also people who don't want to be leaders, but do phenomenal work that contributes to what we are all about. And that's okay too, to not have to feel like you're goaded into becoming a leader. It's not that you're born that way. It's people's choice to do that. I think a lot of it. So whatever you want to do meaningful work. That's really the key point.
And you don't need to have a title to be a leader. Right?
No.
You're being a leader anyway.
Absolutely.
Yeah, and that point you make about everything that we're learning being important. I mean, in school, I learned about pandemics like everybody else.
Yeah.
Oh, they happen every 100 years.
Yeah.
Yeah.
It won't be all 100 years. Thing I know, I'm chairing the governor's COVID task force, right?
Yeah.
I'm trying to figure this out. Okay, well, big thank you to everyone for joining us today, both online and in the auditorium. And thank you to our speakers. So one quick announcement before we depart. We hope you'll mark your calendars for our next Dean's Leaders in Lagniappe lecture on Wednesday, March 11th. We'll be joined by 2 innovative health entrepreneurs, Dr. Rebecca Gee and Dr. Adeze Inikwachi, who have both successfully started their for-profit businesses coming out of illustrious public health careers. I want to stress for-profit, that you can also start for-profit businesses in public health. The point is having a business model that works. So please join us for refreshments and the art exhibit out in the ball gallery. And thank you all.
Thanks.